What we saw was that, again, the only difference was that the number of new territory affected was slightly higher as compared to controls, but the serious adverse events were similar, the bleeding was similar, and the pneumonia rates were similar, and the rates of hemicraniectomy for severe stroke were also similar. If you compare this with other emergency treatments, such as a IV thrombolysis for STEMI, the number needed to treat is as high as 43 patients. But for thrombectomy, it's as low as 3 patients to 7 patients. So again, it's turned out to be one of the most powerful treatments in medicine. And the best part is that in the subgroups of treatment in patients who did not receive TPA because of contraindications or they came a little late, there was still benefit. If the patients came later in the time window, there was still benefit. And then the most dramatic subgroup was age more than 80 resulted still in benefit. And there was a question whether older patients could benefit from this or not. But again, age did not decrease the benefit of thrombectomy, and all the different severity categories also showed benefit. So this was a very powerful step forward for stroke treatment in 2015, and I had the privilege of co-writing the guideline change from American Heart and American Stroke Association, saying that mechanical thrombectomy is the new standard of care. What we did find also with the meta-analysis of these 6 trials is that the benefit of treatment, even within the first 6 hours, declines as time passes. And so this means that these outcomes are highly time sensitive, and the surgery needs to be done extremely fast without any delay. So if you look at the numbers about what every 15-minute faster treatment results in, 39 more patients out of 1,000 would be less disabled if the reperfusion was done 15 minutes faster, and 25 would be completely independent. And therefore, the American Heart and American Stroke Association guideline is for a level 1 and level of evidence A recommendation that patients should receive mechanical thrombectomy with a stent retriever if they are not disabled at baseline, they have a internal carotid or MCA occlusion, they are adult, and their stroke score is 6 or more, and the CT aspect score is 6 or more, and the treatment can be initiated within 6 hours of symptom onset. This again changed in 2018 when 2 trials showed that there can be benefit even beyond the 6-hour window. And this is because even when patients wake up from sleep, they have pretty small strokes, and a number of them take a long time for the strokes to grow based on good collaterals that they have. Some patients are not that fortunate, but for these patients who do have good collaterals, they can have benefit, we think, of up to 24 hours. This was then proven in a study called the DAWN study that was published in the New England Journal of Medicine, as were the previous trials, that showed that in patients who were treated with thrombectomy with the device called Trevo, which is a stent retriever, the outcomes were significantly better in treated patients as compared to controls when they were between 6 and 24 hours from symptom onset. The patients were selected with a perfusion imaging, CT perfusion, or MR perfusion, and those that had brain to save were the ones that were selected in the trial. And if the vessel was opened, they resulted in a 48% chance of being independent as compared to only 13% if they did not receive thrombectomy. And this was repeated in a parallel trial that was called Diffuse 3 that again showed similar results, about 50% chance of 0 to 2 Rankin scale, which means the patient is independent if they got endovascular therapy, versus only about 16% chance of being independent if they did not get thrombectomy. And so this is, in the interest of time, I'm going to go a little faster. This is the standard for stroke with a large vessel occlusion now, and this is pre-COVID-19, where anybody between 0 to 4.5 hours gets IVTPA, gets a CT angiogram. If they have a large artery block, they get mechanical thrombectomy. Between 4.5 to 6 hours, they go straight from CT angiogram to mechanical thrombectomy if they have a large vessel occlusion. If they are a wake-up stroke, or between 6 and 24 hours, they get a CTA and a CT perfusion. And sometimes, if the CT perfusion is not helpful, a diffusion-weighted imaging with MRI, and then a mechanical thrombectomy in the angiography suite. But what happens in COVID-19? This was the story I was telling you in the beginning, and I will now finish in the next 4 minutes. This patient, as you remember, was a 48-year-old. He did not have any respiratory symptoms. Stroke was his presenting symptom. He was positive in the ED. The patient was brought to a negative pressure room, intubated, and was taken to thrombectomy under PPE. And what you see is that the stent retriever, these are the markers of the stent retriever, pulled out one clot and then went for the second clot with this stent retriever in the clot that I showed you before. And then we achieved a complete reperfusion. And the clot that came out had on histology, had a large number of leukocytes, suggesting this very high inflammatory nature of the clot in COVID-19. And this was the final stroke that this patient had. He had a good reperfusion, and he remained aphasic but was able to follow commands. And then this was at basically 4 days after the thrombectomy, and he was moving the right side with 4/5 strength by day 4. His lungs did show evidence of COVID, but he did quite well respiratory-wise with treatment. What we found in our retrospective cohort of 10 stroke centers, and this was a study I did with Dr. Khandelwal, who is my former trainee and is in New Jersey, and 10 other centers. Out of 6,698 COVID-19 patients admitted to 10 stroke centers in COVID hotspots, both in the US and outside, the incidence of stroke was about 1.3%. But out of all those strokes, the rate of large vessel occlusion was 60%. Typically, the rate of large vessel occlusion is about 20% to 30%, but in COVID-positive patients, that rate was nearly double or a little more. The median age was 51 years in the LVO patients, so much younger age, and African Americans were affected in higher proportion. And what we found was that this was seen in multiple other studies. What was really very heartening was the response of the LVOs to standard treatment with mechanical thrombectomy was excellent, similar to pre-COVID data. So the clots are not more resistant to thrombectomy, and we can achieve similar results. This is another paper by my friend, Dr. Janardhan, who's from Chennai originally, who practices in the US. And these are various COVID-positive stroke patients that had really good results with thrombectomy. But look at the large clot burden that COVID-19 patients have. This is much more than usual. And again, they have leukocytes like in the patient I showed you. What is very important, again, is that preoperatively, one has to, during this pandemic, suspect every patient to be possibly COVID positive. And if you don't have a test, treat them as COVID positive. Before a CTA of the head and neck, consider CT of the chest just as a diagnostic possibility that can show you COVID lung. And then during this procedure, limit the number of people in the procedure. And at our center, we actually intubate in the negative pressure room with the anesthesiologist in full PPE. That allows much less exposure in the angio suite. And postoperatively, the patient should be extubated not in the angiography suite, but in a negative pressure room later on outside the angiography suite. So in summary, COVID-19 causes significant hypercoagulability, and ischemic stroke is increased by approximately 2% above baseline. The vast majority of stroke is in the form of a severe large vessel occlusion in COVID-19 patients. Mechanical thrombectomy, thankfully, is now available at several centers, including centers in India, and is highly effective and safe for LVO stroke up to 24 hours from symptom onset. and this is the new standard of care since 2015, despite the 24-hour window, outcomes are better with earlier reperfusion even within this time window. So treatment should not be delayed at all. Mechanical thrombectomy in COVID-19 patients is equally safe and effective as in COVID-19 patients, and a COVID-19 specific protocol needs to be in place in the angiography suite so that proper PPE precautions and intubation can be done in COVID-19 patients without exposing healthcare workers to the to COVID during the mechanical thrombectomy surgery. We are working hard with several leaders in India and around the globe to increase access to thrombectomy for stroke patients, and a nonprofit campaign called Mission Thrombectomy 2020, and now it's called 2020 Plus, aims to double the access to thrombectomy every 2 years. Thank you so much. I really appreciate your attention, and I'm happy to take questions.
Thank you, sir. Thank you for a wonderful session. Your experience with the patients who underwent the thrombectomy for stroke really helpful for the students. And before allowing you to sleep, we have some questions from the audience. A few questions only, sir. First thing is, would routine anticoagulants help prevent complications of COVID? What should be the INR be then? So this is the first question.
That's a great question, and there is quite a good body of literature supporting that approach. The INR that's aimed for is the typical INR above 2, typically between 2 to 3, and it remains to be seen if the newer anticoagulants are any superior to Coumadin. But right now, either of the anticoagulant class can be used, and I think that is becoming fairly routine to use at least heparin in the ICU, and then on the floor to use oral anticoagulants in COVID patients.
Okay. The second question is, when do we start anticoagulants in COVID patients, and how long should it be continued?
Yeah, we have been starting anticoagulants in any hospitalized patient on day 1, typically with heparin, and we have continued it at discharge up to about 7 days after discharge.
So the third and final most question is, herpes is also associated with large vessel obstruction, but is normally asymptomatic. Why is it different from COVID?
Yeah, the coronaviruses really seem to have this effect on the ACE2 inhibitor that seems to contribute to the hypercoagulability. But we are learning really new knowledge every day about these mechanisms. Herpes virus is not a coronavirus and has a more inflammatory reason for causing large vessel occlusion. So I think the mechanism that coronaviruses have is what leads to hypercoagulability, especially the SARS-CoV-2 virus seems to be extremely hypercoagulable in its effect on the human body.
Sir, I think the questions are over. I again thank you on the behalf of KIMS Medicon 2020 for your wonderful contribution to Covidology. Thank you, sir.
Thank you so much. Thank you all. Have a great meeting.